video of microsurgical management of large recurrent posterior fossa epidermoid. This 60-year gentleman, 23 years back, had cerebellopontine angle epidermoid who had operated and excised, and he was doing well. This time he presented with swaying while walking, difficulty in speaking and swallowing, hoarseness of voice and continuous hiccups. Examination showed gait ataxia, 5th to 12th cranial nerve paresis. He was investigated with contrast MRI scan brain, showed a very large recurrent epidermoid in the posterior fossa surrounding the brainstem, pons and medulla oblongata, and more situated on the right side, significant pressure on the medulla, encircling or engulfing all the cranial nerves from 5 to 12 cranial nerves, and the basilar artery, vertebral artery, and the branches of these vessels as shown in these images, and significant pressure on the cerebellum, lesion going up to the midbrain in the lateral cerebello-brainstem space. This is the MRI images showing the location, extent, and spread of the pathology in the posterior fossa. He was taken up for surgery. This time he underwent midline suboccipital craniotomy, microsurgical subtonsillar inferior cerebellar approach, opening of the capsule, debulking of the tumor starting from the right side, going on to the left side, complete excision of the lesion. We prefer to do posterior fossa craniotomies. Midline incision is made, burr-holes are made below the transverse sinus. With the craniotome cutter, the craniotomy is carried out and the bone is separated. Superiorly, the craniotomy goes up to transverse sinus and torcular, inferiorly up to the foramina magnum. Laterally, it goes on to the lateral side up to the paramedian region, about 1 to 1.5 inches. We take out the bone flap completely in one piece, and bilateral cerebellar hemispheres are exposed. We take out the rim of the foramina magnum and posterior arch of C1. The dura mater is opened in a Y fashion as shown here. Here, due to the extensive recurrence, the dura mater will be adherent to the epidermoid. One needs to be very careful and separate the dura mater gently from the underlying tumor and keep the arachnoid patent and protected all the time. The upper cervicomedullary junction dura mater at the foramina magnum also is retracted with the stay sutures. Next important step is to open the arachnoid on the cisterna magna, starting with a cervicomedullary junction, go up to the superior vermis, laterally into the lateral part of the cervicomedullary junction, and expose the tumor completely, inferiorly and laterally. Next is to open after opening the arachnoid, the capsule of the epidermoid is opened in the cruciate manner. During the opening of the capsule, one must be very careful to observe that this tumor doesn't encase the pica, that is posterior inferior cerebral artery, anterior inferior cerebral artery, lower cranial nerves, 9, 10, 11th, 12th, encase, the encasing. So we need to look for them. Once the capsule is opened, internal debulking started on the right side. Tumor is more on the right side. With sharp dissection, the tumor is separated, keeping in mind, as I mentioned to you earlier, the lower cranial nerves, cervical branch of accessory, cranial branch of accessory, 9th, 10th, and 11th cranial nerves originating from the medulla need to be protected under any circumstances. Now you can see we're going out to the midline. You can see the fourth ventricle there. Floor of the fourth ventricle is exposed, and you can see the tumor adherent to the medulla oblongata on the posterior and lateral aspect, and you can see the perforators from the vertebral artery and pica going into the tubule. Extremely important to protect these perforators going into the medulla and pons is at utmost importance. Now, as we go deeper and deeper, the lateral and anterior part of the tumor into the lateral cerebello-brainstem space is debulked and removed, and the surface epidermoid on the posterior and lateral part of the brainstem, that is medulla oblongata, and cervicomedullary junction is debulked. This is the recurrent epidermoid. It will be very densely adherent to the structures. If it is coming out easily with dissection, sharp dissection, you keep dissecting and taking out. If it is adherent and inseparably fused, we should not attempt to pull it and dissect it, so that during the process, we should not injure the brainstem and the perforators and the vessels and cranial nerves, important cranial nerves, lower cranial nerves, going out of the pons and midbrain. Now you can see the anterior, posterior, and lateral part of the tumor is taken out. We are separating the tumor from the pica, which is encased inside the tumor. That is taken out, and bit of a tumor adherent to the pica is left behind. Now we are going to superior and anterior aspect of the lateral cerebello-brainstem space, and lesion is debulked and removed. Here again, you can see the tumor is not very densely adherent. We can take out very well, and going anteriorly and laterally into the lateral cerebello-brainstem space, deeper part. You can see the trigeminal nerve superiorly and 7th, 8th cranial nerves in the mid, and this is the lowermost part of the tumor into the lateral cerebello-brainstem space at the level of jugular foramen, where the lower cranial nerves, that is 9th, 10th, 11th, and 12th, they go into the jugular foramen and exit out. Now you can see the tumor is taken out completely from anterior, superior, and lateral. The inferior part of the tumor into the inferior lateral cerebello-brainstem space is taken out. That is the 7th, 8th complex. We are on the anterior and lateral aspect of the pons. You can see the 6th nerve there, abducent nerve, and that is the anterior and lateral part of the tumor, densely adherent to the pons and medulla. If it is not coming out easily, we should not attempt to force it and try to get it out. In the process, we will be causing the damage to the midbrain and pons and medulla. So now almost near total excision is done on the right side. Now we come on to the left side of the brainstem. Arachnoid is open laterally, and tumor, you can see the major bulk on the left side is separated from the undersurface of the inferior part of the cerebellum and the cervicomedullary junction and the upper cervical spinal cord into the inferior part of the lateral cerebello-brainstem space. Now you can see the posterior inferior cerebellar artery being encased by the tumor gently with a sharp dissection that is separated from the medulla oblongata and the undersurface of the cerebellum, and tumor is debulked, dissected, and taken out. That's the lateral part of the tumor going into the lateral, inferior, and lateral part of the cerebello-brainstem space. Earlier, we used to call it as cerebellopontine angle, which is a misnomer. We prefer to call it as lateral cerebello-brainstem space. Now the tumor into that inferior part of that space is being dissected from the undersurface of the inferior cerebellum and being taken out. Now that is the inferior part of the tumor is removed, and gently we are going on to the anterior and lateral aspect of the midbrain, pons, and medulla, more so inferior pons and complete medulla oblongata. Again, like what we did on the right side, we need to be here, keep a watch on the lower cranial nerves, which will be encased or engulfed by the tumor. That needs to be understood and gently keep separating under high illumination and high magnification. Keep watching these tumors, dissecting it. Now you can see the tumor is being removed gently from the lateral aspect of the left side brain stem, anterior part and the lateral part, and dissecting the epidermoid from the lower cranial nerves on the left side, that is 9th, 10th, 11th and 12th cranial nerves. We are going anteriorly and laterally, deeper and deeper, and that part of the epidermoid is gently separated. Now you can see the lower cranial nerves on the left side, 9th, 10th and 11th cranial nerves entering into the jugular foramen, originating from the medulla and getting into the jugular foramen are gently dissected and taken out. Every branch of the nerve should be kept patent and protected. Every stage of surgery, you keep washing the area with the pepperine saline to wash the area well and avoid or prevent the vasospasm due to the surgical handling and the chemicals released from the epidermoid, keratin during the dissection, cholesterol and keratin during the dissection, which may cause post-operative vasospasm. Keep washing the area repeatedly and to avoid the vasospasm due to surgical handling and epidermoid chemicals itself. Now you can see the near total excision has been done. You can see the midbrain, pons and medulla, up more so medulla oblongata and lower pons. At this juncture, we would like to bring the endoscope and look into the crevices where microscope may not show us, and look for the remnant tumor and if there is any vascular injury during the dissection, and to achieve hemostasis. Some part of the tumor is so densely adherent to the pons and medulla oblongata and lower midbrain, we'd like to leave it there because you can see the encasement of the basilar artery there and the perforators, and during the process we should not injure the basilar artery and the perforators. Now on the right side, we inspected. Now going to the left side, you can see the fifth nerve and the seventh nerve. Now we are anterior to the brainstem. You can see from the on the right side we are putting this suction, and from the left side we are visualizing that this suggests that anterior part of the tumor also is debulked and taken out. You can see through and through anterior to the brainstem. You can see the basilar artery going and at the perforators of the basilar artery going to the brainstem, that is pons and medulla oblongata. This is the near total excision on both sides. Now this side again, we bring in the endoscope on the left side. You can see the trigeminal nerve there superiorly, totally cleared, and you can see the 7th, 8th complexes and the densely adherent part of the epidermoid. You can see the basilar artery, vertebral artery, perforators going to the brainstem, taken out completely, and you can see the suction tip opposites from the opposite side. You can see from the left side, suggesting taking out the tumor, the part of the tumor anterior to the brainstem, that is the pons, and medulla oblongata is completely removed, and that's the basilar artery anterior to the brainstem of the perforators going to the pons and medulla. Complete excision is done, and part of the epidermoid, which is not dissectable or removable from the brainstem, is left behind. Now you can see the microsurgical anatomy there, lower cranial nerves, cranial and cervical accessory branches, 9th, 10th, 11th cranial nerves going into the jugular fossa. You can see the vertebral artery, posterior inferior cerebellar artery on the right side, complete removal, and similar anatomy we are seeing on the left side. You can see the accessory nerves, cervical and cranial. You can see the lower cranial nerves completely. Absolute hemostasis is achieved and confirmed. We close the dura as much watertight as possible with the fascial graft and achieve the complete closure. The bone is replaced and scalp is closed in 2 layers. Same day evening scan done shows near total excision, no hemorrhage, swelling, edema, and infarction. This is post-operative clinical status on day 2, glaucoma score 15, motor deficits. The preoperative cranial nerve weakness remains and ataxia. This is our neuroanesthesia team, treating physician and neuro rehab team. Our presence online with more than 640 microsurgical, exoscopic, endoscopic, navigation guided, educative neurosurgical operative procedural videos on our YouTube Neurosurgical Video Atlas. Thank you very much for viewing.